Goodenberger. I have a lecture today on fluoroscopy and interventional radiology physics. For this lecture, the RSNA modules will be the fluoroscopy systems and radiation dose and safety monitoring and interventional radiology. And then also there are Huda and Bushberg chapters if you're interested. Also thanks to Dr. Hansen for making the original version of these slides. So fluoroscopy is the real-time imaging with X-ray of dynamic things. So because it uses X-rays, the basic principles are pretty much the same as projection radiography, but because you're imaging things in real time and dynamic things, the exposure times are going to be much longer, and so you have to make changes in the X-ray receptor and how much dose you're giving. So fluoro operates at much lower doses than plain radiography because you're giving exposure over a much longer amount of time, and also you have to have a device that's specially made for this. So fluoroscopy, usually you're using 1 to 5 milliamp current on your X-ray tube and between 60 and 120 kilovolts, kiloelectron volts, and then fluoroscopy machines usually have built-in grids with a 10-to-1 grid ratio. Just a comparison in the differences between fluoroscopy versus radiography. So KVP values are usually similar, but MA, as you can see, we're talking around 0 to 5 or 0 to 100 if you're doing continuous or pulse, compared to 200 to 800 when you're doing radiography. But radiography, your exposure time is very short, fractions of a second compared to minutes for fluoroscopy time. So basic fluoro setup, you're going to have an X-ray tube emitting your X-rays, and then on the other end you're going to have a image intensifier, which receives the X-rays and turns it into readable light signal that then a camera can pick up and send to a monitor that you're looking at. And then between those two things, you put the patient, usually with a table. Although with C-arms, you don't have to do that. So you can have lots of different devices that use fluoroscopic principles. So you know, in the IR suite, you can have C-arms that rotate around a table. You can have, like we do in GI fluoroscopy, the X-ray tube is hidden under the table there, and then you have your image intensifier. But still the same concept. Again, this is in like a neuroangiography suite. You can have a biplane so that you can do fluoroscopy from 2 directions at once. You can have mobile C-arms, so in the operating room, or you know, if you've ever done a swallow study on somebody that's in a wheelchair with the C-arm, those are things that you can do. And then similar, I guess, also to kind of our GI fluoro systems, so you can have these other fluoro systems here. You can also have remotely controlled fluoroscopy, so the patient can be in the room with the fluoro and you're just running the machine in a different room to lower your exposure. And so those are all kind of different fluoro units. So which of the following components is not part of the material that would make up the fixed filtration of a fluoro unit? I'll give you a second to think, and you can pause. Okay, so the plastic window of the X-ray housing, the copper filter, and the aluminum filter, those would all be in the path of the X-ray beam and would be part of what is the filtration. The insulating oil is not part of the filtration. Okay, so the main difference between an X-ray and a fluoro unit is the image intensifier, which is the receptor. So it converts the X-rays that go through the patient into a light image that gets displayed on a TV. It's a vacuum tube, or at least traditionally, this is the analog version. Systems are kind of now going digital, but the analog version was a vacuum tube made of glass or aluminum, and you have an input phosphor that gets hits with X-rays, and then that releases electrons from the photocathode, and then those electrons are focused by a whole bunch of little focusing electrodes until they hit they go towards the anode, and then they hit a fluorescent screen output that then convert it into light. So the input phosphor is most likely made of what? I'll let you pause it if you want to think about it. Okay, so it's most likely made of cesium iodide. Image intensifier component that converts light into electrons. What is that? Think about it for a second. It's the photocathode. Okay, so you can have different size image intensifiers. So you'd have a larger one for abdomen, for example, and a smaller one for cardiac. The input phosphor is made of cesium iodide, converts X-rays into light, and then that knocks electrons off of the cathode part of it. And then those electrons are focused by the lens, like we talked about, and then hits the output phosphor. This intensifies the image because you have electrons from a large area being focused onto a small area, and so the number of electrons per unit area gets increased. And so that's one way that the image intensifier will increase your signal, will make the images is brighter, and that that's a magnification gain, and we'll talk about that here. And then, so the output phosphor light will be much brighter than the light that was from the incoming X-rays. So the overall brightness gain is, how bright was the light from the X-rays at the input screen versus how bright it is at the output gain. And that comes from a couple things. A big part of it is the minification gain. So you have a large area, like we talked about, going to a small area, and so you're going to have related to the area, the ratio of those areas will be what the difference in brightness is, and usually that's on the order of 100. Flux gain is the number of light photons emitted from the output phosphor relative to the input phosphor, and that part of that is from the minification gain, and part of that is just maybe from the acceleration there. And then the overall brightness gain would be the minification gain times the flux gain. So around 100 times 50 would be your answer there. So minification gain, again, you have a large area where the X-rays are hitting, and then those create electrons that are focused onto a smaller area, and so you get a proportional increase related to the size of the areas. So image intensifier conversion factor measures the light output relative to the input. Let you pause and think about it. Okay, it's the air kerma. Okay, so other words, stupid nomenclature. The conversion factor is the measure of the light output of the image intensifier from the air kerma rate. So the number of X-rays hitting the tube relative to the light output of the output phosphor is your conversion factor. So most image intensifiers will have a certain number of candelas per meter relative to the number of micrograys per second. And so, a higher number would be more efficient at converting X-rays to light. Contrast ratio would be the number of light intensities lost through the intensifier process because of scatter and X-rays passing through the system. So fluoro basically has a lower contrast ratio than regular radiography, so it would have a lower contrast ratio. Other things that the machine will do, one of the types of computer magic that fluoro systems have is automatic brightness control. So a fluoro machine will change its KVP or MAS to keep what it thinks is a good image and to keep the overall brightness correct. So it if there's not enough light reaching the camera or reaching the TV, it will up your radiation dose, or vice versa if there's too much. And so the amount of radiation that's coming out of the X-ray tube is always changing. And so so the way that you take your images can really affect the X-ray dose. Also, the more you magnify fluoro, is actually less minification, and so you're taking a smaller area of the photocathode to take where the X-rays are received, and you're sending that to a larger area, or the same area on the output phosphor, and so you get less minification, and so that's what magnification is. But you're going to also have less minification gain, so the image will be darker, so the automatic brightness control will have to up your radiation output. Okay, so minification gain of a typical 10-inch image intensifier is how much? I'll let you pause and think about it. Okay, there it is, 100. Okay, so I touched on this a little bit, but the amount of magnification increases your radiation dose, and this is really important for analog systems. So a typical system, if you're using the whole input phosphor, and then you're using the same side, the whole output phosphor, that large area is going to go to a small area, and so you're going to get a lot more brightness on the output phosphor. If you magnify, all that does is that uses less of the image intensifier, but uses the same amount of output size. So you get the ratio of these areas is not going to be as large, and so you're not going to create the same amount of brightness in the output phosphor unless the way that you keep the same amount of brightness is you have to up your radiation dose, and so that's what the automatic brightness control will do. And so you really up your radiation dose by doing magnification. And it has to do with the ratios of areas. So if you, it's basically a square. So if you cut the size, if you basically you can have to do 4 times the amount of radiation just to keep the same amount of brightness when you cut the size in half, or when you magnify by 2. So it significantly increases the scan doses, and so magnification on an analog system increases skin doses. And also, magnification is not the same as collimating. So if you don't make the actual image larger, but you just collimate, that does not increase doses. And so only use magnification when you need it and for a short period of time to limit the patient dose. And that's important on an analog system. On a digital system, that's not the same. Okay, so separate from magnification is collimation. Collimation reduces patient dose with no loss of image quality, and usually it improves image quality. And that's because the automatic brightness control can set the amount of brightness correctly for that smaller area, and so it'll more likely get a better radiation dose. A smaller area will be exposed, and there's less scatter within the patient, and then there's also less scatter reaching the receptor, and so you'll have better contrast. And then you yourself also will get less exposure because there's less radiation coming from the patient. So fluoro, of course, can have artifacts like anything, and there are artifacts that are unique to fluoro. Lag is one of them, so the phosphors that are used for fluoro will create brightness for a certain period of time after they're hit by an X-ray, and so even after you turn the machine on, there would still be some brightness given off for a while. So that basically creates lag. Now, modern tubes have less lag, and so that's less of an issue. But if you're doing something that's moving really quickly, that could be an issue. The image intensifier also is curved in a lot of cases, although again with digital systems that's not necessarily the case. And this leads to geometric distortion. That's called the pincushion effect. So straight lines appear slightly curved, and I'll show you an example of that in a little bit. And if you do more magnification, then you're using less of the curved part of the image intensifier, and so you'll have less pincushion effect, but then of course you'll increase your dose. And then another thing is saturation. So because the image intensifier is trying to maintain a certain amount of brightness, if you get something really dark, then you can oversaturate the rest, and so you'll get outside of the range that the detector can detect, and it'll just look white. So an example here of saturation, so there's a big hunk of metal, and so all this stuff out here just looks white, even if there's soft tissue and things that you could characterize without that metal. The system got saturated. Okay, a fall in brightness at the periphery of a fluoro image is called, let you think about that for a second. Okay, so it is vignetting. So here is an example of vignetting. So vignetting, basically things in the center would be brighter than things on the periphery. And then another example of what we talked about, that pincushion distortion, where things, even though if these were straight lines, they would look curved towards the periphery. And this is an example of that in a real fluoro image where the center is brighter and the lines maybe look a little bit curved or a little bit more compressed towards the periphery. So Fluoro, of course, has a TV. So it used to be that there would be a TV camera basically aimed at the output phosphor, and that would turn the light into a TV. A lot of them would use a CCD to change that light into charge, and a lot of systems, at least traditionally, the resolution of the whole system was really limited by the TV. However, of course, monitor technology is always increasing, and we've got Retina, iPads, or whatever, and so all that stuff is getting to be where the TV is no longer the weakest link in the resolution of the system. Okay, so flat panel detectors. So this is what most of our machines now are. So they do not have the analog image intensifier. They offer better image quality at a similar radiation dose. They are more expensive than image intensifiers, though like all things digital, things are always getting cheaper. They use a scintillator, so something that converts the X-ray into light, and then that's coupled with a silicon array that converts the light into digital information. And so the system, the Fluoro system, can be direct or indirect, just like digital radiography. Each pixel on the digital system has a part that needs electronics for a readout, and then also has a part that's X-ray sensitive. And so the ratio of the X-ray sensitive part to the whole size of the pixel is called the fill factor. And so a larger fill factor is better in terms of having a larger X-ray sensitive area relative to the amount of electronics, but that's a trade-off because you also want a smaller pixel to have higher resolution. The pitch is the measurement of the detector size. So the smaller the detector elements, the better the resolution. But again, you have to trade off with those electronics, because as you make your pixel smaller, then the electronics take up proportionally a larger amount of the pixel, and so you're less sensitive to X-rays. So automatic brightness control on an IR system attempts to maintain a constant what? Let you pause and think about it. Okay, so it maintains a constant image brightness. Digital fluoro, so a TV camera output. So the output, instead of really having a TV camera, it's just digital output from the detector, and the image data can be processed and filtered for better image quality, and so the digital fluoro images look nicer. Also, this allows for last image hold technique, which keeps the last frame of whatever you're fluoroing up on the screen, so you don't have to hold on to the fluoro button to be able to see, to be able to look at whatever's going on. You can stop it and then look for a little bit, and you don't have to keep radiating the patient. And so this can lower doses, and it's required on all new fluoro units. Pulsed fluoro is another technology that is pretty much universal, but didn't used to always be there. So rather than having the X-ray on the entire time while you're fluoroing, you just do short pulses at a certain number of frames per second, or pulses per second. And so usually it's 30 or less. 7.5 to 15 would be typical, but you can definitely do even fewer frames per second on things that don't require a lot of motion or a lot of time resolution. So something that might require a lot of time resolution, like neuroangio, where seeing a particular vessel at just the right time is very important, you might do the 30 frames per second. Whereas if you're doing something like advancing a feeding tube, you don't need a lot of frames per second, so you could do 3 frames per second. That would really lower your dose. The dose per frame goes up because you're not continuously sending the X-rays through, but so you have to increase the dose per frame a little bit to overcome that noise. But overall, because you're not radiating all the time, the overall dose goes low. So if you're doing 30 pulses per second, you're looking at like a 20 to 30% less dose, or 15 would be 40 to 60% less dose than doing continuous fluoro. So we pretty much never do continuous fluoro. Spot images. So spot images are more or less diagnostic quality images obtained from the fluoro machine. And so traditionally what they would do is they would put a screen film in front of the II and then use that X-ray tube to take an exposure. And now, of course, we've got digital receptors that either that are placed in front of the eye or are part of the machinery. And so the tube current from the X-ray tube increases for those, and so for that single exposure you're going to get a lot higher dose, but you're going to have a lot higher resolution as well. So you can do last image hold, which is just saving the last frame from a fluoro study, but that's going to be low resolution. But if you want high resolution diagnostic quality image and you do it in exposure, you can do that, but of course you're going to have a higher dose. And in general, 5 to 10 spots will have the same dose as about 1 minute of continuous fluoro. There are also other features that fluoro units can have that are more specific to IR. For example, you can have road maps, so you can capture an image and display it on one monitor, and then have real-time fluoro on the other, so that if you inject contrast into an artery and you want to keep that image up while you're advancing the catheter, having those two monitors and having that road map is useful. Another thing would be subtraction is useful. So another question here: digital subtraction images are least likely to provide information regarding vessel what? I'm going to pause that and let you think. Okay, so digital subtraction least likely to give you information about calcifications, because those would be subtracted out. But when you inject contrast, you will see things like flow or stenosis or turbulence or patency. So digital subtraction angiography, so what you do is you take a pre-injection image and then you do exposures while you're injecting, and you subtract the pre-injection out of that, and that's why it's called digital subtraction angiography, and it lets you see only the iodine, at least in an ideal situation. And so here, this would be what the image looks like without subtraction, and here it is with subtraction. And so it kind of removes a lot of that competing signal from the bones and skin and things like that. Of course, there are issues with motion, either from cardiac motion or breathing or just the patient moving, and then you get misregistration and the subtraction doesn't work as well. Okay, so fluoro dose is a frequently tested topic. Many machine parameters have a profound effect on patient dose. So your X-ray tube voltage and current, your collimation, beam filtration, automatic brightness control, and if you use pulsed fluoro, those will affect dose. So if you increase your kVp by 15%, what will that do to your X-ray dose? Let you pause and think about it. Okay, so the answer there is that it approximately doubles. How about patient dose related to the MA or the beam on time? How is that related? Should you pause if you want to think about it? Okay, so the answer there is they're directly related. So if you double your MAs, you double your dose, or if you double your beam on time, you double your dose. So not as strongly related as kVp. So the thicker the patient, the more output you get from the automatic brightness control, and then you get a higher dose. Most of the radiation is absorbed in the first few centimeters of the skin, and so if you have larger patients, you'll have fewer X-rays that reach the image detector, and so the automatic exposure control cranks up radiation. And so just an example here, you can use this as a thickness of acrylic plastic used to stimulate a patient. And so you can see as you go from 10 to 25 centimeters, the dose goes up. And just an example of how most of the dose is scattered or absorbed within the patient, and only a minority of the X-rays go through. And same image there as the thickness goes up. The tube kVp will be increased by the automatic exposure control, which then increases dose. And this shows how the dose goes up with the increased thickness. All right, so there are ways that you can reduce the thickness. You can image, if you need to image a patient, you can try to image them through the thinner part instead of the thicker part, so like in the abdomen rather than going transverse. If you go anterior to posterior, if you can do that and get your images, that'll help. Also, try to not do things like this, where you're obliquing through the patient, so the overall thickness that the machine sees is going to be more. Whereas if you could do a straight AP here, there would be less thickness and so less dose. Also, overlapping beams you might think that you're not radiating the same area, but you might get a higher dose to the skin right in that area where they overlap. And then also your pulse rate, that can affect your dose. So there's examples of different pulse rates. Oh, sorry, let's see here. Going from 5, 10, all the way up to 30. So, of course, the higher dose rate will have a higher radiation exposure, whereas a lower pulse rate will have a lower exposure. Okay, so kind of overall effective dose of different procedures. So fluoro procedures are some of the highest radiation procedures that we have, that along with nuclear medicine studies. So cardiac angiography, barium enema, GI fluoroscopy, those are all in the order of 10 to even hundreds of millisieverts, which, just for reference, like an abdomen and pelvis CT is kind of in the order of 10 to 15, and mammography and X-ray are less than 1. And just more and more example in terms of the doses of different procedures. And so neuro or embolization type procedures will be pretty high. TIPS will be pretty high. Things that you can do really quickly, like place a IVC filter, will be lower. Okay, so radiation, not just the patient, but how do you protect yourself from less radiation? So you can be exposed by primary beam. So if you put yourself in the path of the beam, you can get exposed to radiation. You could be exposed by radiation leaking out of the X-ray tube, and then you're exposed by radiation scattered from the patient. And the best way to reduce these things is always time, by reducing the amount of time, increasing your distance, and increasing your shielding. And the amount of radiation that you get exposed to drops off as far as your distance gets from the radiation source. And so this is that example, because the radiation is expanding not just linear, but over a surface area or an area, and so the drop-off is exponential. It's a reverse square law. So the farther away you get, if you can double your distance, then it'd be the square root of 2 would be the amount of radiation you get. So not just half. I think maybe I'm saying that wrong. Let's see here. So just an example of how quickly things fall off. So here right next to the patient, we're talking like 4 milligrays per hour, whereas if you step back just a little distance, it goes down to 1 or 0.25. So each little distance can make a big difference. And then just another example here about how right next to the patient, where that scatters, is going to be the highest level of radiation, where as you get away from the patient, the amount of radiation drops off pretty quickly. And also within the patient, because most of those X-rays are hitting the back of the patient and are being absorbed or scattered there, and as you get through to the other side of the patient, there are fewer X-rays because they've already been absorbed or scattered, then there's less absorption and scattering happen on the far side of the patient. And so a lot of the scattering is going to be backwards through the patient down towards the floor or down towards your feet. I guess, which is fortunate, because a lot of your most radiation-sensitive organs aren't right there. But there will be some scatter radiation coming out the sides of the patient. And so if you create a bubble of kind of where the highest radiation is around the patient, immediately posterior to towards the X-ray tube from the patient is where the highest radiation is going to be, and then there'll still be quite a bit of radiation also anterior to where they are, towards the detector side, but it'll be less relatively. And so, of course, you can do all kinds of things to reduce your exposure. You can use leaded glasses, you can use leaded aprons, you can use shields, you can have leaded aprons around the patient, and then you can also do time and distance. So just examples of leaded glasses and leaded shields that are hanging from the ceiling that you can use in IR, so you can still see the patient, you can still see what you're doing, but kind of get it out of the way. So what's the annual radiation exposure limit, whole body exposure limit for radiation workers? I'll pause this and let you think about it. Okay, so the answer was 50 there. Okay, so quality assurance. Fluoro units get quality assurance tests at regular intervals, just like everything else. I don't know that it's worth trying to memorize what they are and how often they get, but just knowing that they exist. So you can use a mesh pattern to test resolution, or line bar patterns to test resolution. This will also give you ideas of vignetting or pincushing defect. You can also test contrast with different types of phantoms here. And there's a mesh to show that vignetting and curvature. Okay, so how do you protect patients from getting too much exposure? We kind of talked about how to protect you. So you try to keep things out of the way that don't need to be in the way. For example, try to get arms out of the way if they don't need to be in the path of the radiation beam. Just an example of an arm that was in the way of a fluoro procedure and the radiation necrosis having to be debrided. Only use magnification when you need. Don't keep the beam on if you're not looking or if you're not using it to get information that you need. Use collimation whenever you can. Only have the area that you're interested in the field of view. Use last image hold or save for documentation. Don't do full exposures unless you really need the full resolution. Make sure that the test is indicated and it's being done at the right time on the right patient. Do things like continuous, like cine continuous exposures, high frame rates, and digital subtraction angiography runs to a minimum. Avoid lateral or oblique views because you're going through the thickest parts of the patient that way. Keep the image receptor as close to the patient as possible so that you're able to collect as many photons as you can. You're not losing too many to scatter. And maintain your source to skin distance as far as possible. If the radiation alarm goes off, pay attention to it and really consider if you're doing what you need to do, if you have choices, anything you can do to reduce radiation. So how low, though, is low enough for a patient? Well, you keep it as low as reasonably achievable because the worst thing you could do is make a study non-diagnostic. So to go through the whole effort of doing the study and everything, but if you make such efforts to lower radiation dose to the point that you can't answer their question or you can't help the patient, well then whatever radiation you used was not worth it. And so you need to use at least as much and hopefully just enough to answer the question. Thank you.